Hello, everyone. My name is Luis Puig. I'm a dermatologist from Barcelona in Spain and member of the Education Committee of BRAPA. My co-facilitator, Professor Jörg Ehrman, from the Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts, will be together in presenting it will be our pleasure to welcome you to this Globe Education Symposium from GRAPA and Spartan. This is the first edition, most convenient for the Americas time zone, of the fourth of 6 seminars that are to be held over the course of the year, and this one will cover comorbidities. Over the course of this seminar, we will be presenting, first of all, the information and also the perspectives of our patient research partners, Arnon Katz and Dennis O'Sullivan from Israel and Ireland, and they will provide their patient perspective. Then we have some pre-test questions, which will be put forward by Jörg Ehrman, and then I will introduce the presenters of the cardiovascular disease or cardiovascular comorbidities in psoriasis. It will be Professor Wolf-Henning Benke from Geneva. On psoriatic arthritis, Lai Shan Tam from Hong Kong. And then Dr. Liane Gensler will be presenting the data on cardiovascular disease, and she will provide the view from the ankylosing spondylitis clinic at San Francisco, California. After that, we will present some further questions. All of them will be answered by the attendees, and the final answers will be given at the end of this activity. Then Professor James Rosenbaum will discuss the uveitis in spondyloarthritis. We'll have some other questions, and then Professor Diamond Tachi from Kiel will talk on the gut comorbidities and the role of the microbiome in psoriasis, psoriatic arthritis, and axial spondyloarthritis. And then we will have a moderated panel discussion after the answer of all the questions that have been put during the course of this session. And we will moderate this, Professor Ehrman and myself, together with panelists Arnon Katz, Wolf-Henning Benke, Liane Gensler, James Rosenbaum, and Jose Scher. And we look forward to having a most interesting and attractive session. With no more ado, these are our disclosures, and I would like to introduce our patient research partners, that is Arnon Katz and Dennis O'Sullivan.
Comorbidities and burden to patients in PSA. Hello, my name is Dennis. I'm from Ireland. Diagnosed with PSA in 1999.
Hi, I'm Arnon from Israel, diagnosed with PSA since 2002. From my experience and from other patients, I learned that PSA has many accompanying related conditions and side effects.
I have the same impression from PRPs I have spoken to about issues relating to the disease and the medications.
Many physicians mentioned possible complications of the disease, such as cardiovascular problems, uveitis, and gut microbiome. Yet, patients are worried by additional issues, for example, reflux, possibly caused by the medications themselves.
Patients experience problems such as colds, skin irritations, and infections more easily, and are slower to recover. We feel medications required may worsen our overall health.
Issues related to the gastrointestinal system, obesity, inflammatory bowel disease, symptoms such as heartburn and digestion, bloating, constipation, and prolonged coughing, all these need additional medications, and they can possibly interact with PSA itself and its medications.
Fatigue and sleep worries, constant high-level fatigue, getting tired easily, and fear from the extreme impact of sleep issues on health, mood, relations, and resilience.
A real up-to-date concern is related to the possible interaction between PSA and COVID-19. Should we take the vaccine? What are the possible effects of taking it? Does the type of vaccine taken influence differently our treatments for PSA? And with our compromised autoimmune system, will there be a need for any additional special care or treatment?
Patients are worried that their doctors do not pay enough attention to psychological issues. Patients refer to issues such as depression, nervousness, anxiety, unstable moods, and guilt due to their offspring inheriting the disease. Actions that patients would appreciate from their doctors.
Doctors, explain to the patients what to expect about PSA and its comorbidities and what to look out for. Patients need to understand what problems are and are not due to the PSA or its medications. Tell them about useful websites or other resources of information.
Improve screening and patient awareness of broader comorbidity issues, e.g. waiting room completion of problems such as PSA-12 or pre-appointment questionnaires.
Patient worries. Possible interactions between PSA, comorbidities, and the medications, and long-range effects, including, for example, high risk for cancer and heart problems of the medications, for example, from the biological medications.
Doctors, encourage and make it easier for patients to talk to you. Be aware of patient life impacts, such as inability to work or engage in leisure or social activities. Be prepared for wide-ranging questions, e.g. can sleep issues such as sleep apnea be connected to PSA? What should patients consider when planning a family? How should we monitor for offspring's potential to inherit our disease? To conclude,
Patients experience problems and they seek their doctor's help for these. They may not know which problem is due to the disease itself or to any related conditions or due to the medications or any other problems.
please be aware that PSA and its related conditions may impact on all areas of the patient's life. The complete effect of the quality of the life of the patient should be considered, and not only dealing with the pure medical situation of PSA.
We thank you all for listening to our perspective, and please consider what you heard.
Yeah, so good afternoon, good evening, or good morning. This is Jörg Ehrman here. I'm a co-moderator for this session, and this is our first pre-test question. Those of you who have participated in this activity know how that works. We have 3 times 2 questions that will return at the end. For those of you who are new to this, these are questions, they're all multiple choice, and we want you to select the best answer. The responses will help us to tell us about how well the organizers and people who were involved in preparing this session, how well we did with the teaching, but the questions are also designed to direct your attention to certain topics throughout this program. So here's question number 1. Which of the following statements about cardiovascular disease in patients with psoriasis and psoriatic arthritis is correct? GWAS, genome-wide association studies have shown that psoriasis and psoriatic arthritis share multiple risk loci with metabolic syndrome and coronary artery disease. Increased insulin sensitivity of vascular endothelial cells may contribute to CVD risk in patients with psoriatic disease. The Framingham risk score underestimates the risk for CVD in patients with psoriatic arthritis. Or EULAR recommends that CVD risk assessment for patients with inflammatory rheumatic diseases, including PSA, is performed at diagnosis and subsequently every 10 years.
And you have 5 quick seconds to answer the question. 5, 4, 3, 2, 1, 0.
Okay, let's go to question number 2. Aortic valve disease and conduction defects are well-recognized complications in ankylosing spondylitis. What is the most appropriate approach to screen patients with axial spondyloarthritis or AS for these conditions, using transthoracic echocardiograms or electrocardiograms? A, screen all axSpA and AS patients after 10 years of disease. B, screen all axSpA AS patients with more than 2 cardiovascular disease risk factors. C, screen all AS patients, so only the AS patients who had more than 5 years of disease without being on biologic therapy. Or D, mandatory screening is not recommended.
Again, 5 quick seconds. 5, 4, 3, 2, 1, 0.
Okay, thank you.
So now we are getting ready to start the round of presentations on cardiovascular disease, first in psoriasis by Professor Wolf-Henning Böhnke, then in psoriatic arthritis by Professor Lai-Shan Tam, and finally on axial spondyloarthritis by Professor Lian Gensler.
Hello everybody, my name is Henning Böhnke and I'm excited to be part of the GRAPPA Spartan Global Education Virtual Seminar Series 2021. My topic is psoriasis and cardiovascular comorbidities. We'll briefly describe the problem based on immunological data and then discuss causes of this issue at the level of genetics and pathophysiology, and finally, of course, address clinical consequences in this context. Now, this paper from 1995 already describes a number of what we call today comorbidities. It talks about diabetes, heart disease, etc. And we do know by now that there is a number of comorbidities in psoriasis patients. Here, a list of what I would consider the canonical comorbidities of that disease. All of them are really established now at the level of systemic literature reviews or meta-analysis to be associated with psoriasis. And noteworthy, the metabolic syndrome or parts thereof are associated with psoriasis. Now, the question is, of course, why that is the case, and the potential explanation could be shared genetics. So there is data that suggests that there is a shared genetic control of psoriasis and some comorbidities. This meta-analysis here looked at a number of genome-wide association studies and found shared loci for psoriasis and Crohn's disease. And I find this publication particularly interesting because it describes an insulin-responsive enzyme with a mutation that could actually link psoriasis to hypertension and namely diabetes. However, we had a thorough investigation of the whole catalog of genome-wide association studies that has so far been published and could not find any link between psoriasis and the genetics of these comorbidities. However, as a control, if you want, we did see in this analysis shared loci between the metabolic syndrome and coronary heart disease. So our conclusion from this analysis is that shared genetics cannot explain what we see clinically. Now, what we do see clinically is a solid dose effect in the sense that severe psoriasis, shown here, but not mild psoriasis, is associated with an increased risk of cardiovascular disease, as shown by Joel Gelfond's famous study that was a population-based study. In parallel, Ralf Ludwig, in a case control study, looked at coronary artery calcification and that allowed the conclusion that psoriasis should be considered an independent cardiovascular risk factor. And if you look at all the publications throughout the last 15 years or so, we come to the conclusion that mild psoriasis is not associated with a higher cardiovascular risk, whereas moderate to severe psoriasis shows this effect. Now, is this reasonable? Do we have a good explanation for that? Pathophysiology helps us to understand that this actually may be real. In order to understand that, we have to know that the insulin receptor is expressed on the vast majority of cells in our body, not just metabolically active cells such as musculoskeletal cells, but also endothelial cells. And once insulin binds to its receptor, it kicks off two signal transduction cascades. One that at the level of endothelium is protective, anti-atherogenic if you want, and another cascade that actually results in pro-atherogenic effects. And the key information on this slide is that once there is inflammation, at this level of this kinase here, the signal transduction cascades towards the protective effects is shut down, and all that remains is the cascade towards the pro-atherogenic effects, as I'm going to show you in the next slide. So you will see the generation of an inflammatory milieu in human endothelial cells and the inactivation of this cascade here. So this is PKB, and we are looking at the phosphorylation of this kinase, so activation after binding of insulin to its receptor. And you see that in these human dermal blood endothelial cells, insulin usually activates the kinase, whereas this effect is blocked in the presence of a cocktail of pro-inflammatory cytokines, psoriatic cytokines, including IL-23, TNF, etc. And when we quantify it, we see a solid effect. Now, this was the key stone for the concept of the psoriatic march, which is a concept that is readily accepted in the world of diabetology, where obesity is considered a systemic inflammatory condition, which results in insulin resistance, which at the level of the endothelial cells causes a dysfunction, stiffness, which is the basis for atherosclerosis and finally causes myocardial infarction, or at the level of the brain, stroke. And Dee and others have shown that every step of this cascade can also be triggered by psoriasis, which needs to be considered a systemic inflammatory condition. So, preliminary summary on the discussion whether or not psoriasis should be considered an independent cardiovascular risk factor. Epidemiologically, I've shown you the dose effect, whereas it remains true that, of course, many of the cardiovascular risk factors are present in our patients with psoriasis. So the hen and egg question is still somewhat open. Genetically, there are studies that show that the genetic control of psoriasis and its comorbidities can clearly be separated, and others that show that at least at certain levels there seem to be some genetic overlap. Pathophysiologically, namely the phenomenon of insulin resistance is key to psoriasis as well as atherosclerosis, as well as numerous other factors. It has to be acknowledged that we do not understand everything in detail. For example, the role of IL-17A is it pro-atherogenic, anti-atherogenic, still is a matter of debate. But what I think we need to stress is that all we see at the level of the skin, including the obvious comorbidities of our patients, is just the tip of the iceberg. And psoriasis really is a systemic inflammatory condition which can be made visible by PET CTs like this one from Nihal Mehta. You see the inflammation at the level of the skin, the joints, the liver, but also the endothelial cells compared to a normal person. So this is the two dimensions of psoriasis explaining the cardiovascular risk of those patients. An interesting question is whether we can reduce the patient's risk through treating the systemic inflammation. Now, 10 years ago, we did such a study looking at the blood flow in the blood vessels. And you see a dose response curve here prior to treatment and 6 months into a systemic treatment for psoriasis, and you see an increase in the blood flow. So we increase the elasticity of the blood vessels, and this is a sign that we reduce the patient's cardiovascular risk. That particular study was done with fumaric acid esters, and 1 year later, another group published a similar study. You see the same effect, this time using the TNF-alpha blocking adalimumab. And more recently, 2 years ago, the KARIMA study was published looking at zicokinumab, and there too you see an improvement in blood flow under the treatment. So this is a surrogate marker. As of now, we do not have a study on hard endpoints, so mortality. But at least at the level of surrogate markers, we do have the impression that continuous systemic anti-inflammatory therapy for psoriasis tends to reduce the patient's cardiovascular risk based on surrogate markers for that risk. Clinically, it is important to address comorbidities. This paper, almost 10 years old, shows a comprehensive algorithm for the most important comorbidities. So again, obesity, hypertension, dyslipidemia, diabetes, or the metabolic syndrome as large, as well as numerous other ones. And I just want to highlight that as of today, repetitively new and updated recommendations have been published, like this one from the American Academy of Dermatology, in a joint effort with the National Psoriasis Foundation, that stresses, when it comes to cardiovascular risk of the patient, that a risk assessment has to be done in each and every patient with psoriasis, be it mild or moderate or severe. A screening in patients with moderate to severe disease should be done early and more frequently than routinely done. Very important, there are risk score models that help GPs, internists to define treatment goals for hypertension, diabetes control, etc. The respective risks should be multiplied by a factor of 1.5 to address the extra risk that is induced by psoriasis. This is in line with what the rheumatologists say with regard to rheumatoid arthritis. And then, of course, the issues have to be addressed actively, be it by the GP or the dermatologist. So in summary, psoriasis is associated with increased cardiovascular risk. Insulin resistance may contribute to atherosclerosis in these patients. There are still contradictory data on the question of whether anti-inflammatory treatment of psoriasis results truly in a reduced cardiovascular risk. But what is without doubt true is that patients with moderate to severe psoriasis need to be screened early and regularly for their cardiovascular risk profile. Thank you very much.
Hello, everyone. I'm Professor Lai Shantan from the Chinese University of Hong Kong. I'd like to discuss with you regarding the risk assessment of cardiovascular comorbidities in patients with psoriatic arthritis. Indeed, circulatory diseases was the leading cause of death in PsA patients, and they have a standardized mortality ratio of 1.3 due to cardiovascular diseases compared to the general population. And in a meta-analysis recruiting more than 30,000 patients have demonstrated that cardiovascular morbidity was increased by 43%. So if we look at the EULAR recommendation for cardiovascular risk assessment published a few years ago, cardiovascular risk assessment is recommended for all patients with inflammatory arthritis, including patients with psoriatic arthritis, according to the national guidelines. So let's look at this patient. He's a 45-year-old male with normal lipid profile who's a smoker, no history of diabetes or high blood pressure. So the Framingham risk score was 9.4, which was considered not high. So what would you consider? Well, the problem is Framingham risk score underestimates the true cardiovascular risk profile in newly diagnosed PsA patients. So if we use the 1.5 multiplication factor to compensate for the lack of inclusion of inflammation. These adaptations do not improve discriminatory ability and calibration amongst PSA patients. And all the cardiovascular risk scores also underestimate the risk of subclinical atherosclerosis in PSA. And this modification only improves the sensitivity of the Framingham risk score and the ASCVD risk score to a moderate level. So what else can we consider? Actually, Euler recommend to consider performing high-resolution ultrasound to look for carotid plaque. So on the left-hand side, this is a very nice and smooth carotid artery. And on the right-hand side, you can see a protrusion highlighted by the arrow. This is the atherosclerotic plaque, which indicates an increase in cardiovascular risk. Indeed, we look at 100 patients with PSA followed for 10 years, and the presence of carotid plaque at baseline was associated with a 2 to 3-fold increase in risk of developing cardiovascular event, even after adjusting for disease activity and cardiovascular risk factors. So back to our patient. In view of the presence of subclinical atherosclerosis, high risk of carotid atherosclerosis, we performed a carotid ultrasound for this patient, and indeed we found a carotid plaque. So what would you do in patients with the presence of carotid plaque? Would you start statins or perform a coronary CT angiogram or refer to cardiologist? Well, we've looked at our patients, 90 PSA patients compared to 240 age, sex, and cardiovascular risk factor matched control. We were actually quite surprised to find that 60% of our PSA patients actually harbored a coronary plaque, and the prevalence was doubled compared to the control, signifies that a lot of our PSA patients actually had silent coronary ischemia. So in view of this finding, we did proceed to order a coronary CT angiogram, which surprisingly actually revealed triple vessel disease, and the calcium score was more than 1,000. So he was diagnosed to have ischemic heart disease and referred to a cardiologist. And we started him on aspirin and statin, and the cardiologist performed coronary angiography and PCI on the left anterior descending artery, and he was also treated with clopidogrel for a year. Of course, we cannot overemphasize the benefit of a healthy diet, regular exercise, and smoking cessation for all our patients. And antihypertensives and statins should be considered as similar to the general population. And the prescription of NSAID should be, with caution, especially in patients with documented cardiovascular disease or in the presence of cardiovascular risk factors. Please do not forget, inflammation was actually driving the premature atherosclerosis. So we followed this patient prospectively according to a special protocol aiming at achieving MDA, and we, after followed them for 2 years, patients who achieved sustained MDA indeed had a reduced risk of subclinical atherosclerosis progression. In summary, ladies and gentlemen, psoriatic arthritis patients are at risk of premature atherosclerosis because of the systemic interacting with the metabolic risk factors. So in patients with doubt, we can consider imaging study to help us for the cardiovascular risk assessment. Effective suppression of inflammation and treatment of cardiovascular risk factors may prevent progression of subclinical atherosclerosis and cardiovascular events. Thank you very much for your attention.
I'm Leanne Gensler. I'm now going to present the risk assessment of cardiovascular comorbidities in axial spondyloarthritis. I framed this as thinking about the risk factors, disease, and mortality in axial spondyloarthritis, and then thinking about other manifestations and the role of medications on both the outcome of cardiovascular disease and the related risk factors. So first, thinking about the risk factors and understanding this relationship between the risk factors, the disease, and then medications and their impact perhaps directly on cardiovascular disease or indirectly on inflammation, which then affects cardiovascular disease. A recent meta-analysis looked at these cardiovascular risk factors in a pooled number of studies and showed far and away the most common cardiovascular risk factor is hypertension, as you might expect, affecting approximately 23% of patients with axial spondyloarthritis. But other cardiovascular risk factors are also common, and thinking about them as we think about treating our patients is very important. If you look at these risk factors in comparison to control populations, you see that the pooled odds is significantly higher in axial spondyloarthritis. However, beyond coronary artery disease, which is the most common manifestation, we should also think about valvular disease and conduction disease in axial spondyloarthritis. And I'll talk about a little bit about those and how to risk stratify for those patients. Now thinking about the prevalence of the manifestations, not the risk factors in axial spondyloarthritis, from the same meta-analysis in 120,000 patients, you can see that the most common cardiovascular manifestation is ischemic heart disease, but other manifestations do occur, and the question is, do these occur at a higher rate or more frequently than they would occur in non-axial spondyloarthritis controls? So addressing that with a meta-analysis, this is the most recent one, looking at cardiovascular events, including MI and stroke, showing that ankylosing spondylitis patients in these studies had a higher odds of both myocardial infarction and stroke, with an odds of 1.6 and 1.5 respectively. Now, sometimes we think about, is this the disease that is a higher risk? In other words, we definitely associate rheumatoid arthritis with cardiovascular events, and is it different in spondyloarthritis? So addressing that from the Swiss Clinical Quality Management Registry, they looked at both the adjusted and unadjusted incident rate of ratio of the cardiovascular events that can occur in rheumatoid arthritis, axial spondyloarthritis, and psoriatic arthritis. And though the unadjusted rates were higher in rheumatoid arthritis, when you adjust out the risk factors and thinking about age, which in axial spondyloarthritis is going to be a significant confounder and may make axial spondyloarthritis look more protective, you see actually very similar adjusted rate ratios of these cardiovascular events. As we think about vascular mortality in axial spondyloarthritis, this is from the Ontario population data, where you can see that the adjusted hazard of mortality from vascular disease and events was significantly higher compared to the non-axial spondyloarthritis controls. However, when you stratify by men and women, you see that this is most significant in men, and in fact, in women, it crosses the confidence interval of 1. In a subpopulation of these patients where medication data were available, as you might expect, statins were associated with a lower association with mortality. However, interestingly, NSAID use was also associated with a lower adjusted hazard of vascular mortality that was not seen in COX-2 selective inhibitors, but more broadly in NSAIDs. Now, thinking more about statins, this is from the British Thin data set, where they looked at the association with mortality in ankylosing spondylitis over 5 years of follow-up and showed within AS patients, statin users or initiators compared to non-initiators had a significantly lower risk of mortality compared to those that did not initiate statins, and this was after propensity score adjustment, so really thinking about trying to address confounding by indication in this population, suggesting that statin use may be quite important in patients with axial spondyloarthritis, especially when adjusting for those other risk factors. The aortic root is fascinating to think about in valvular disease in axial spondyloarthritis because the aortic root is thought to be an enthesis. And so when you look at the aortic root, in a mouse model in particular, you see the same resident lymphocytes that secrete IL-17A and IL-22 on IL-23 binding as you do in other enthesial areas. And it's thought that inflammation then leads to a dilated aortic root and aortic insufficiency. Past older studies showed a significant association with AI and even lone AI in patients with spondyloarthritis and in association with B27. And the question is that a true association, or is there some publication bias here or selection bias as you study these small populations of patients? Conduction disease has also been associated with axial spondyloarthritis in big epidemiologic studies, population registries, and then in smaller studies. And the question is, despite this association, including complete heart block and lower degrees of AV block, in addition to atrial fibrillation, should we be screening these patients to risk stratify them for this cardiovascular outcome? To look at the association of valvular heart disease and conduction disease in ankylosing spondylitis, Michael Ward used the Medicare data set and published this in the Journal of American Heart Association and showed that patients with AS did have a slightly higher adjusted odds of having valvular heart disease and, in fact, aortic valve repair, not mitral valve repair, interestingly, but that risk was small compared to the general population. In addition, when he looked at pacemaker implantation, again, that prevalence range from 1 to 7.6% significantly increased as you went up in age, and you could see each of these colors represent a different age category. However, when compared to the relative risk of the general population, that risk is relatively flat. And so the recommendation in terms of screening for these both valvular and conduction disease in adults with ankylosing spondylitis and axial spondyloarthritis is that we strongly recommend against screening, in other words, patients that don't have symptoms for conduction defects with electrocardiograms or transthoracic echoes for valvular disease unless they have symptoms. As we think about medication effects on cardiovascular outcomes or risk factors in this case, we studied the effect of NSAID use, particularly continuous high-dose use in ankylosing spondylitis, and noted in our SOAS cohort that in patients that did not have a prior history of hypertension, there was a significant association with the incidence of hypertension in patients that were using high-dose or continuous NSAIDs compared to those using on-demand or no use. However, the hazard ratio was significant but small, with about a 12-point increase in the risk of developing incident hypertension in high-dose NSAID users. A recent meta-analysis looking at the impact of NSAIDs and TNF inhibitors on cardiovascular endpoints in axial spondyloarthritis, with most of the data deriving from NSAID exposure, showed no harm from these agents on cardiovascular endpoints, and in fact potentially some benefit from NSAIDs on overall cardiovascular endpoints. If you look at the sub-endpoints with ischemic heart disease and acute coronary syndrome, you see that there's no association with benefit or harm on NSAID exposure. However, when you look at stroke as an endpoint, what you see is that there does appear to be benefit, and that is particularly associated with COX-2 selective inhibitors over non-selective NSAIDs. In summary, cardiovascular risk factors are common in axial spondyloarthritis, though manifestations are rare. Those studies are limited. Strong evidence to screen patients for cardiovascular disease as you would in other inflammatory arthritides, except for manifestations like valvular disease and conduction disease unless there are symptoms. Medications have minimal to no effect on the risk factors, and NSAID should be used in caution in patients with cardiovascular disease, with really longer-term studies on biologics on these cardiovascular endpoints needed.
So here's pre-question number 3. What we are doing slightly differently this time is that we'll bundle all the post questions at the end, just prior to the question and answer session. And I would like to encourage you also to use the chat window to ask questions to the presenters for the Q&A at the end of the program. So pre-question number 3. Which of the following is a typical feature of uveitis associated with ankylosing spondylitis? Sudden onset without prodrome, bilateral disease, discharge and crusting, a small pupil or pupils on exam, or the absence of hypopyon.
Let's count down fishery auction style. 50, 40, 30, 20, 10, done, gone. Next.
This is true teamwork here. So question number 4. What is the likelihood that a patient who is HLA-B27 with unilateral acute anterior uveitis has spondyloarthritis? Is that likelihood 5%, 20%, 50%, or 80%?
Now Chris's style. 10, 10, 10, 15, 15, 20, 25, 25, 30, 30, 30, 40, 50, 50, gone. And now we are going to the next presentation by Professor Jim Rosenbaum. He will discuss uveitis, and he's the chair in the Division of Arthritis and Rheumatic Diseases and professor of ophthalmology, medicine, and cell biology at Oregon Health Science and University of Portland.
My name is Jim Rosenbaum, and I have the honor of telling you about the most important extraarticular manifestation of spondyloarthritis, namely uveitis, although I confess that I have a slight bias that the eye is the most important organ in the body. I've given myself an agenda. I'm going to try to define uveitis. I'll tell you what the prototype is for uveitis in association with ankylosing spondylitis. Then I'll show you how uveitis differs in psoriatic arthritis compared to ankylosing spondylitis. And I'll briefly talk about the biologics that are effective for uveitis. This is a cartoon of the eye. The eye is 2.5 centimeters from front to back. The front is modified skin. The back is neurologic tissue. Some people say an extension of the brain. I like to say that the brain is an extension of the eye. The uvea is shown here in purple. So the anterior uvea is the iris. Then there's the ciliary body and the choroid, which is sandwiched between the sclera and the retina. Now, any part of the uveal tract could be inflamed. So subsets of uveitis include iritis or anterior uveitis, iridocyclitis when the ciliary body is also inflamed, choroiditis, and then when the choroid's inflamed, adjacent tissue is often inflamed, so you have chorioretinitis or retinochoroiditis, a vitritis or intermediate uveitis if the inflammation is centered here behind the lens, and when all aspects of the uvea are inflamed, we call it a pan-uveitis. Now, we've recognized since 1973 that there's an association between HLA-B27 and acute anterior uveitis, as depicted here with a unilateral red eye and a pupil that's smaller because the ciliary body muscles are in spasm. Even though we've recognized this association for 48 years, we still don't really know the mechanism that accounts for the association. What we do know is that in Europe and North America, spondyloarthritis is easily the most common systemic disease associated with uveitis. Now, these data that I'm going to share with you next came from a Spanish study that represented a collaboration between rheumatologists and ophthalmologists. It was called the Sentinel Study, and it was published in 2016, I believe. In this study, nearly 800 individuals with acute anterior uveitis were enrolled. And the very first question asked of these individuals was, do you have known spondyloarthritis? If the answer was yes, the individuals were excluded. And while I've discussed this with the authors, they couldn't tell me exactly how many people were excluded. But you can see of those with acute anterior uveitis, the majority, 475, are HLA-B27 positive, and the authors concluded that 71% of those had axial spondyloarthritis and 21.9% had peripheral spondyloarthritis. I also asked the authors how many had both, and they couldn't tell me, but I think it's a reasonable estimate to say that about 80% of individuals who are HLA-B27 positive with acute anterior uveitis have an associated spondyloarthritis, and there are a number of other studies that support that conclusion. Maybe a bit more surprising was that they also included over 300 people with recurrent anterior uveitis who were HLA-B27 negative. Now, to be B27 negative in this study, you had to have more than one episode of anterior uveitis. But even in these B27 negative individuals, they concluded that nearly 20% had associated axial spondyloarthritis and 11% had peripheral spondyloarthritis. So there's a close connection between acute anterior uveitis and spondyloarthropathy. We can ask the converse. If you have ankylosing spondylitis, what's your risk of developing acute anterior uveitis? I think the best data related to this were published in 2015 in Arthritis and Rheumatology. It was a study about the genetics of acute anterior uveitis and ankylosing spondylitis. And the study concluded that there were genes that specifically predisposed to uveitis without predisposing to ankylosing spondylitis. But this study included a huge number of patients and a variable duration of illness, up to 50 plus years. And as you can see, when you capture individuals who have had spondyloarthritis for 40 years or more than half report having had at least one episode of acute anterior uveitis. So the characteristics of HLA-B27 associated acute anterior uveitis are incredibly consistent, and I'll actually show you some data to support this conclusion in a moment. But almost always, the inflammation is in the front of the eye, so it's an anterior uveitis predominantly. Patients who have recurrent episodes, and recurrence is the rule, they tend to know when the recurrence is about to occur, just as a patient with a migraine knows of a prodrome. So they will be able to tell you that inflammation is on its way even before you can see that inflammation with a slit lamp examination. The ophthalmologist would describe the inflammation as non-granulomatous, and that's a description usually based on the cells that deposit on the back of the cornea. These are called chorotic precipitates. The inflammation is self-limited in general. It goes away within several days to several months at the most. It only affects one eye at a time, but when it recurs, it might recur in the opposite eye, but again, only one eye will be active at a time. The pressure tends to go down, and that's important because herpes simplex causes a recurrent anterior uveitis with the pressure going up. And there are complications such as posterior synechii, fibrin, and something called hypopyon. This is hypopyon-associated uveitis, pus in the anterior chamber. It was a subject of a report from the University of Southern California 30 years ago. I was taught in medical school that hypopyon-associated uveitis is almost always Behçet's, but in Los Angeles, they found that 80% of the hypopyon-associated uveitis that was not due to an infection was HLA-B27 related. In a paper that my colleagues and I wrote more than 20 years ago, we compared the uveitis associated with spondyloarthritis in purple with the uveitis associated with inflammatory bowel disease. Spondyloarthritis in this instance refers to ankylosing spondylitis or axial spondyloarthritis. And what you can see is that rarely was this inflammation bilateral, whereas with inflammatory bowel disease, Crohn's or ulcerative colitis, almost 2/3 of the time it was bilateral. It tended instead with ankylosing spondylitis to affect one eye, or it could flip-flop, as I said, recur in the contralateral eye, but not be active in both eyes. Whereas it was a minority of patients with Crohn's or ulcerative colitis who had that flip-flopping pattern or that unilateral pattern. And HLA-B27 was associated with nearly 90% of the ankylosing spondylitis patients who had uveitis, where it was around 50% of the Crohn's disease patients who had uveitis. I'm going to show you similar data for psoriatic arthritis in just a moment. This is a recent publication that used a meta-analysis to ask the question, is psoriasis or psoriatic arthritis associated with uveitis? And what they found, combining data from various studies, is that yes, psoriasis does have a relative risk of about 1.5 for increasing the likelihood of uveitis, and the confidence interval does not cross 1. With psoriatic arthritis, the risk of uveitis is higher. And if you flip it around, if you have uveitis, you have an increased likelihood of developing psoriasis. And among patients with uveitis, there is an increased risk of finding psoriatic arthritis. So 21 years ago, my colleagues and I performed a study on the uveitis associated with psoriatic arthritis that was very much like our study on inflammatory bowel disease and ankylosing spondylitis. And interestingly, psoriatic arthritis and inflammatory bowel disease were basically indistinguishable in terms of the patterns of uveitis. So with ankylosing spondylitis, the uveitis starts suddenly. It's almost never insidious, but sometimes it is insidious with psoriatic arthritis. I showed you earlier that it is not bilateral, at least not simultaneously bilateral, but that's common in psoriatic arthritis. I said that the uveitis was self-limited, whereas a chronic uveitis occurs in psoriatic arthritis. I told you that it's usually anterior and rarely posterior to the lens, but it's quite common in psoriatic arthritis to have inflammation that is in the vitreous humor or posterior to the lens. And finally, when it comes to therapy, the therapy really depends on the location. Is it anterior, posterior, panuveitis? And it depends on the severity. So I fit the punishment to the crime. Ophthalmologists generally treat non-infectious uveitis with corticosteroid drops and then oral corticosteroids, sometimes corticosteroid injections into or around the eye. And if those fail, an antimetabolite is a good choice. Methotrexate is probably the most common choice. In terms of biologics, at least in the United States, adalimumab is the only FDA-approved biologic to treat non-infectious, intermediate, posterior panuveitis in adults. And the FDA has also approved adalimumab to treat any form of uveitis in children. IL-17 antagonists, of course, are very effective for psoriasis. They were trialed in 3 randomized controlled studies for various forms of uveitis, and none of those studies reached the primary endpoint. However, a subsequent study used IV secukinumab at a higher dosage and did report some encouraging results. Still, this is not an FDA-approved indication for secukinumab. So in conclusion, uveitis is the most common clinically apparent association of ankylosing spondylitis that's non-articular. And 80% of patients with HLA-B27 associated acute anterior uveitis have some form of spondyloarthritis. Uveitis is associated with psoriasis and psoriatic arthritis, but the association is much stronger with ankylosing spondylitis. And the clinical presentation in association with psoriasis or psoriatic arthritis is much more diverse than the clinical presentation with ankylosing spondylitis. Thank you for the opportunity to share this information. Los Angeles, they found that 80% of the hypopyon-associated uveitis that was not due to an infection,
Okay.
HLA-B27 related.
So now it's about time for the pre-question 5. Professor Ehrman? It's which of the following statements about the human microbiome is correct? First, the human body is inhabited by about 10 trillion microbes, about equal to the number of body cells. 2, about 500 to 1,000 species of bacteria live in the human gut. 3, firmicutes and protobacteria are the most common phyla in the intestine. And 4, the microbial diversity on the skin is higher than in the gut. Now we'll count down Korsakoff dementia style. So 5, 4, 5, 3, 4, 1, 0. Thank you. Now let's go for the next question on IBD. So on microbiome, which statement reflects the current state of knowledge about the role of gut microbiota in psoriasis, psoriatic arthritis, and axial spondyloarthritis? Select the best answer. 1, gut microbiota affect bioavailability and efficacy of oral DMARDs. 2, dysbiotic gut microbiota induce skin homing pathogenic lymphocytes in psoriasis. 3, molecular mimicry between gut microbiota and HLA-B27 drives sacroiliac joint inflammation in axial spondyloarthritis. And finally, increased production of short-chain fatty acids by dysbiotic gut microbiota enhances systemic inflammation. We have 5 seconds to answer. Done. Okay, so now let's go for the next presentation by Professor Diamond Tachi from the inflammatory unit in Kiel.
Ladies and gentlemen, dear colleagues, I'm very pleased to share with you my presentation about the role of microbiome in psoriasis, psoriatic arthritis, and also spondyloarthritis. The human microbiome is the aggregate of all microbiomes which live within a certain region. Today, I'm focusing on the microbiome of the gut and also the microbiome of the skin. Once we are looking how many microorganisms do we host, as a human we have 10 trillion cells, but how many cells which are driven from microorganisms do we host? 100 trillion cells. So sometimes we are asking ourselves, are we more bacterium than human, since the number is 10 times higher than that what we have as a human. We are learning also that the microbiome has a diversity. The microbiome diversity in the stool is not as high as, for example, on the skin. As you can see also in the tongue, for example, it's more, and also the metabolic pathways are very crucial. Sometimes we are learning more about the phyla. For example, that we have 500 to 1,000 bacteria species who live in the human gut, but they do belong to only few phyla. Firmicutes, which are also in the skin, and Bacteroides, which are also more commonly on the gut, but also others are present in the gut. We have learned more about the microbiome in a recent 5 years, about the fecal microbiota transplantation as a novel treatment option, and the gastroenterologist has the first one using this in their daily practice. Once the first results come, it was very encouraging. We have in some reports clinical improvement of 92%, in some of them 0. And we all somehow confused what should believe, what is true and what is not. Today we know there are some diseases which are caused by Clostridium difficile. This is responding to 90% if the patient do the fecal microbiota transplantation. In UC, improvement is also not bad, 30 to 40%, but in Crohn's disease is even less. And what are the ways to do the transplantation? One way you don't want to know, and the other way, transcolonoscopic, is not also easy one, but it's probably manageable. Nasoduodenal, not the best one. I think the oral capsules could be, but is not used as frequently as the others. So the question is, what is the hotspot today? The intestinal microbiome is becoming the hotspot. The gut microbiota is playing a very crucial role. In the past 5 years, there have been so many publications that gut microbiota is leading not only to the inflammatory bowel disease, but is having also access to the brain, access to the immune system, access to the non-alcoholic fatty liver, to arthritis, to the insulin resistance, etc. And of course, you will hear a lot of publication where this diet, that diet, this improves the gut microbiota. And also, you might read that the composition of intestinal microbiota is associated with many diseases. Just recently, it was presented and published in Science, melanoma and also microbiome. So microbiome is involved everywhere. Atherosclerosis, non-alcoholic fatty liver, rheumatoid arthritis, autoimmune diseases. Wow, so many different diseases. And how it starts? It usually starts with a leaky gut. What is the meaning of the leaky gut? Leaky gut means that this is a normal symbiotic intestinal microbiota. And usually the healthy epithelial cells are producing, for example, no TNF or IL-23 or IL-1 beta. But in the case that we have dysbiosis of microbiota, this is leading to the different way, the opposite way. So inflamed epithelial cells is activating Th17 and they are producing in the opposite way the TNF, IL-23 and IL-1 beta. And the pattern recognition receptors, these are activated in the skin. These are activated in the joints, and we have the psoriasis and the psoriatic arthritis. The leaky gut, what does this mean? If you look carefully, for example, in psoriasis and psoriatic arthritis, it is not intestinal dysbiosis caused only by the food. It is also caused by what kind of the pets we have, what kind of the meals we are taking, what kind of the activities we are doing. So it's very complex. However, it depends if it's going in this direction or toward the increased production of trimethylamine. And trimethylamine, which is a part of the metabolism, this may penetrate to the leaky gut, and this leak on the gut is leading to the accumulation of TMA, trimethylamine, which in the liver is metabolized to a product which goes TMO, oxidized, and this is pro-atherogenic. This is the way how we are understanding that what we eat, the activities that we are doing according to the intestinal dysbiosis. This is also the way how we are explaining in a part, for example, atherosclerosis in patients with psoriasis and psoriatic arthritis. At the other side, the other way is also the activation of the naive T cells, which is happening by the certain bacteria. They penetrate, they may activate, and they will inhibit the activation of the regular T cells, which will stop the activity of the naive T cells and promote them toward of Th17 effector cells. Is there any association of psoriasis with the gut? Yes. The leaky gut is leading to the activation of toll-like receptors. We mentioned the non-alcoholic fatty liver, the leaky brain blood barrier is also leading to more depression because of the cytokines which are interfering with depression. But in the skin, IL-17 especially is increasing the inflammation in psoriasis, which at the other side is increasing the leaky gut. And this is leading toward a more severe disease of the leaky gut. And this is leading also to more depression and more systemic inflammation. We have this association of psoriasis with the brain-skin axis, brain and gut axis, but also gut-skin axis. This also to exist. So we are learning that inflammation on the skin is leading to inflammation in the gut, and the gut at the opposite side, the gut is leading to the brain and depression. There is a very good understanding today of depression caused mainly by the inflammation and axis gut, brain, skin. What about the other diseases, like for example spondyloarthritis? There are a lot of theories, and it looks like that at the very early beginning the dysbiosis, the gut microbiome, may play an important role. You might see that antimicrobial peptides, like defensine, for example, are also important, and the production of cytokines like IL-13, 23, 17, and also the others may lead to improvement, or in case of Th17, like for example IL-23 and also IL-17 cells, this may lead to the more inflammation. And inflammation in the gut, all these cytokines, TNF-alpha, IL-17, IL-23, and this may go in the circulation and have a systemic effect. This is in a part at least explaining at the beginning, early spondyloarthritis. The question which is come, are the bacteria or are probably the fungal infection? From the group of McGonigal, they are trying to show that fungal infection is leading toward the CART9 activation, NF-kappa B, ARC kinases, and pro-inflammatory cytokine secretion. Probably bacteria are not playing such an important role in a spondyloarthritis. In the past, it was thought that spondyloarthritis is very much linked with bacteria, but today, not. And if we carefully look to this one, axial spondyloarthritis is very frequently associated also with Crohn's disease. But whatever, even if it's associated with Crohn's disease, if you do the microbiome, there is no big difference. There's a minimal evidence of gut dysbiosis in axial spondyloarthritis. Independently, if you are looking to the classes or you are looking to the family. Even if you go to the families, you don't see a big difference because the diversity is higher in axSpA than in health control, much higher than in Crohn's disease, and even similar if the patient have Crohn's disease and also axSpA. So in psoriasis, there is a link. In psoriatic arthritis, there is a link, but not in axSpA. There is not so much difference in this direction. Is microbiome in the gut also important for drug metabolism? Yes. So it's not only which kind of microbiome do we have, but also what kind of the dietary compounds is in the intestinum, which drugs and which environmental chemicals are there. For example, if you have an active drug and due to the microbiome, it could be inactive. You might have a prodrug and through the microbiome is changing active drug. Or for example, you have interference and the bioavailability is changed because of the microorganisms which are in the gut. And this is reality. For example, if you look on the sulfasalazine, if you see the sulfasalazine in the gut, is leading to the active compound. If you take the methotrexate, it's a biotransformation. We don't know how it's happening, but we know that in the gut, it might be an inactive metabolite, which is leading to the lower bioavailability of the methotrexate. And this is dependent by the biotransformation of the drug into active and inactive metabolites due to the gut intestinum and bacteria are there. And the other part is, for example, with diclofenac. So the biotransformation is leading to the compounds which are toxic. So today, gut microbiome is playing an important role, not only as a leaky gut in activation of the inflammatory diseases, but also on the drug metabolism and also the physiology in general. We are learning also in psoriasis, once we are looking on pathophysiology, that also microorganisms are playing a very important role. From the books, it is known if you have psoriasis, in small children, you are looking to the tonsil if they have a tonsillitis. This was known association. Patients, especially children, have a gutata psoriasis, which is leading to the more severe disease and the first exacerbation of the disease. And today we know it's not only the tonsillitis caused by streptococci, it is also the microbiome in the pharynx which is changed, and it is a dysbiosis on the pharynx which is also making it possible that streptococci and even staphylococci are leading to more frequent tonsillitis. This is the pharynx control. As more the diversity is, it is better for general for protecting us. But if the diversity is lower, then we have a problem. Then the probability that pathogenic bacteria will come is even higher. So today we are asking ourselves, do skin microbiota trigger psoriasis? It's everything about intestinal microbiota, gut microbiota, or it's the skin microbiota. Dermatologists would think skin microbiota. And the presence of 17 and 23, and especially of 17, is leading toward psoriasis, and presence of 23, in the absence of 17, is leading to the Crohn's disease. Psoriasis is not an immune disease. We have some explanation today why it acts like autoimmune one, but it's not one. So microbiome in the skin is much more complicated. Performing skin microbiome, it is like a method to the madness. You have to select properly your patient. We need to have a swab from a certain area, and then all the analyses are very complicated. However, this is very promising. It is also promising because if you take the scalp of the patient, control have a different microbiome. If you take the scalp of the patient, non-lesional one, you see, oh, there is an increase of Staphylococcus and also on Corynebacterium. But if you look on the lesional skin, then it's a lot of Staphylococcus, a lot of Corynebacterium, less patient with Propionibacterium. So we are understanding that what is in the scalp important is not important on elbow. But some of these phyla are very important, and especially once we are looking at a Staphylococcus and Corynebacterium seems to have and to play a very important role in the skin of the patient with psoriasis. Learning more, we are going toward the role of microbiome in psoriasis, moving from the description to a treatment selection. And it could be that in the very near future, we're looking carefully which treatment are we using and how the treatment that we are using, for example, TNF, 17 and 23, is changing the potential microbiome. Is this reality today? We can say yes. There are at least 10 skin diseases where the microbiome and dysbiosis and skin condition are playing a very important role. And among of that, high abundance, especially for Staphylococcus and Streptococcus in patients with psoriasis, seems to be of the particular importance. Moving toward of that, what is important? It's the microbiome or the probably antimicrobial peptides like catalycidine. Catalycidine together with DNA, this is leading as an antigen to the activation of dendritic cells and may lead to more production of Th17 cells. Antimicrobial peptides like catalycidine may attract the polymorphonuclear cells, and maybe also that what is attracting the inflammation in the skin, like Kugo's pastel and the other sides, is also leading as a chemoattractant that we have more neutrophils in the skin. So the question is, it's a microbiome or this other antimicrobial peptide? And the third question that we are asking ourselves are probably bacterial metabolites or dietary components which are having an effect. For example, if you take, let's say, vitamin D, this suppresses inflammation in IBD. Something in the skin, not reported. Of course it's reported. The vitamin D is having a positive effect also in psoriasis. If you look, for example, on gluten, this is leading to the celiac disease, but it may have also important on the skin rashes. So we are learning it's important. Bacterial metabolism, but also dietary components are very crucial. Coming to the end of my talk, today we are changing our thought. In the past, the contact with the environment should be avoided. The contact with microorganisms was prohibited. And today, even if you look on the Nature publication, it's called puppy power. Once anathema now seems to be the dirty environment can enrich the microbiome and can protect sometimes from some diseases, or at the other side may cause other diseases. So with this, I would like to thank you very much for your attention.
Okay, let's go quickly through our post questions before we go to the panel. And again, I would like to encourage you to post your questions in the chat window. Post question number 1. Which of the following statements about cardiovascular disease in patients with psoriasis and psoriatic arthritis is correct? A. Genome-wide association studies have shown that psoriasis and psoriatic arthritis share multiple risk loci with metabolic syndrome and coronary artery disease. B. Increased insulin sensitivity of vascular endothelial cells may contribute to cardiovascular disease risk in patients with psoriatic disease. C. The Framingham risk score underestimates the risk for cardiovascular disease in patients with psoriatic arthritis. Or D. EULAR recommends cardiovascular risk assessment for patients with inflammatory rheumatic diseases at diagnosis in every 10 years.
I'm sure everyone has ticked the right response, so time is over. Next.
Yeah, not much discussion needed here. So we all go home with this knowledge. Next slide. Question number 2. Aortic valve disease and conduction defects are well-recognized complications in ankylosing spondylitis. What is the most appropriate screening approach for patients with axial spondyloarthritis and AS? A, screen all patients with X-SPAN AS after 10 years of disease. B, screen all patients with X-SPAN AS with 2 or more risk factors. C, screen all AS patients who had more than 5 years of disease without being on a biologic. Or D, mandatory screening is not recommended.
Okay. Some time, and we're about to close now.
All right, so this is about the same, I think, as before. So Dr. Gensler talked about this question, and maybe we can look at it again in the panel. So the correct answer here would be D. Mandatory screening is not recommended because although this is a well-recognized complication, it's very rare, and therefore screening is not standard unless there are symptoms. Can we go to the next slide? Question number 3. Which of the following is a typical feature of uveitis associated with ankylosing spondylitis? Sudden onset without prodrome, bilateral disease, discharge and crusting, a small pupil on exam, or the absence of hypopyon?
Okay, so some hesitation, and the poll is closed.
Okay, so the correct answer here is actually small pupil on exam. It's a bit of a trick question because, of course, the typical uveitis is an acute uveitis, so sudden onset. But as Dr. Rosenbaum discussed, typically patients have a prodrome, so they feel that something is coming on. So sudden onset with prodrome would be the correct answer here. Let's go to the next question. What is the likelihood that a patient who is HLA-B27 with unilateral acute anterior uveitis has spondyloarthritis? Is it 5%, 20%, 50%, or 80%?
Okay. Just 4 options. Closing now.
Yeah, so there has been a clear shift from the pre-test. So this is a very common thing. And so the correct answer here is 80%.
Great.
Question number 5. Which of the following statements about the human microbiome is correct? The human body is inhabited by about 10 trillion microbes, which is equal to the number of body cells. About 500 to 1,000 species of bacteria live in the human gut. Firmicutes and proteobacteria are the most common phyla in the intestine. Or lastly, the microbial diversity on the skin is higher than in the gut. And that was, I think, not the correct version here. So we'll skip that option number 4. So focus on the first 3 possible answers.
Okay. Well, time to close. Not easy. Not easy.
Yeah, and so maybe I'll leave that to the panel to go over these answers again.
Okay, so I would like to apologize to my good friend Ivan Tachi. He is professor and head of the Comprehensive Center of Inflammation Medicine at the University of Lübeck in Germany, Schleswig-Holstein.
And question number 6. Which statement reflects the current state of knowledge about the role of gut microbiota in psoriasis, psoriatic arthritis, or axial spondyloarthritis? And I want to emphasize, select the best answer. So A, gut microbiota affect bioavailability and efficacy of oral DMARDs. B, dysbiotic gut microbiota induce skin-homing pathogenic lymphocytes in psoriasis. C, molecular mimicry between gut microbiota and HLA-B27 drives sacroiliac joint inflammation, axial spondyloarthritis. Or D, the increased production of short-chain fatty acids by dysbiotic gut microbiota enhances systemic inflammation. So it's the increased production of short-chain fatty acids.
Several can be correct. One is the best. Closing in 3, 2, 1, now.
Okay, and the majority picked option number 1, and that's also the best answer. I think that for some of the others, like B and C, this is more at this point hypothetical, but there is solid evidence for the first option here that the bacteria in the gut actually do have an impact on the metabolism of the drugs that we eat.
Okay, so but we will have Professor Jose Scher, who is director of the New York University Psoriatic Arthritis Center and Microbiome Center for Rheumatology and Autoimmunity, and an assistant professor of the New York University School of Medicine at New York. And he, together with Leon Gensler, Arnon Katz, Jim Rosenbaum, and Jürgerman and myself will be the panel in order to discuss and answer questions. So we are ready to start. So please, Jürgen, we have some questions from our attendees.
Yeah, so there were some questions about the management of comorbidities, in particular cardiovascular disease, and maybe I give this both to the patient representatives and to the physicians. So what is the best approach here? Who should do the screening? The specialists, the primary care doctors, and how do you approach that in clinical practice?
Who are you directing the question to first, Jörg? Maybe
you start.
Well, I think it's so much a shared decision, right? So the patient is at the table with you when you're having this discussion about screening and then what to do with cardiovascular risk. So maybe let's ask the patients first how they feel about management of these comorbidities in the setting of their inflammatory disease.
Well, we're looking at it as being a real holistic systemic problem. It involves everything together, and it is a very complicated disease, as we've just seen from the lectures. Now, of course, the patient knows the best what troubles him, but he doesn't have the knowledge, the theoretical, the practical knowledge. So actually, we're speaking about a teamwork, patient with his physician and with all the professionals around. And I think the key issue of competing with this disease is having a panel of experts with the patient, one listen to the other, and then we go into another issue, that each patient is for himself, and probably this disease will lead more into going on to medication or treatment, which is per patient and not per disease.
Yeah, I agree that we personalize our treatment approaches in a holistic way to treat the patient in addition to sort of the associated comorbidities. I think it also depends on the region you're practicing in. So different countries probably have different preferences as to who manages cardiovascular disease. And it also depends on who the primary care doctor is. I have some patients that I co-manage with primary care doctors where the primary care doctor really wants to manage the cardiovascular risk And so then my role is to just identify the fact that patients with spondyloarthritis have an increased cardiovascular risk, and that goes into my assessment and plan. And then I sort of ask the patient to discuss that risk with their primary care doctor. And then when they come back and see me and it's not yet done, or the patient isn't on a statin despite their risk score being elevated, then I sometimes will reach out to the primary care doctor, and sometimes I just sort of then reinforce it with the patient. We have and we use Epic as an electronic medical record, and so we have a smart set that allows us to pull in the data that automatically calculates an ASCVD risk score. And so I do that a lot with patients, and then I go through sort of what the recommendations are from the ACC as an example.
We have one question for Professor Rosenbaum. In a patient with anterior uveitis and positive HLA-B27, but absolutely no clinical or radiological evidence of spondyloarthritis, how far do you go to make a diagnosis?
Well, I don't press it. If indeed there are no back pain and no other joint symptoms, no enthesopathy, I accept that they're in the 20% that escape the combination.
I'll make a comment there as well, Jim, obviously deferring to you as the expert, but I also will sort of caution us as we are evaluating patients for spondyloarthritis in the setting of B27 uveitis that particularly in young patients, they may not have developed the arthritis yet. And so I also it's not you don't have spondyloarthritis, close the door, you don't need to see me again. Sometimes it's also just we're going to monitor you. You don't have it right now, but that doesn't mean you will never develop it.
Yeah, no, it's an excellent point. Although usually the uveitis follows the arthritis, but not always.
And we have one question for Professor Scher. On one hand, the attendee would like to that you discuss a little bit further the molecular mimicry issue. And on the other hand, if a patient asks for dietary advice, what should we tell him or her?
Thanks for the question. I was reading it and I was looking at Jim actually. And molecular mimicry has been around for a long period of time, particularly when it comes to HLA-B27. It's challenging. Some of it has been described in the context of reactive arthritis, and that's how the field has evolved. I don't know that we have identified any antigen that could provide that substrate for pathogenesis. And so that's why it's challenging. Jörg was referring to that this is hypothetical in many ways. Now, I know from work from Jim and Mark that and some of our work that HLA-B27 actually shapes the microbiome in many ways. And so I just wanted to say that a lot of work in the field is going that way. And perhaps the question is how much of the antigenic load in the gut is actually included in the downstream inflammatory effects of the microbiome. And that may perhaps be part of what we call molecular mimicry. In terms of diet, I know from psoriatic disease patients that I see all the time that it's about losing weight. However you achieve that, I don't care. Just lose 5% of your body mass index and then you'll do better. Will you do perfect? No, but there's several studies out there showing that lowering or losing weight will not only decrease the chances of progressing to PSA if you have psoriasis, but also will increase the likelihood of achieving minimal disease activity, particularly in those patients that initiate TNF blockade. And so everything else, I don't know, it's anecdotal for the most part. Mediterranean diet, sure, there's evidence for that. Anything else, you show me the data and I'll believe it.
Okay, excellent.
Can I ask a follow-up question?
Of course.
So, you are a specialist for gut microbiota, and we heard about changes, dysbiotic changes on the skin of patients with psoriasis. Can I ask you, Jose, to do two things? Number one, can you define for the audience what dysbiosis mean? And number two, how do we know whether dysbiosis is the chicken or the egg? Is it the result of inflammation or is it the driver of inflammation?
both the chicken and the egg. So dysbiosis is an alteration or perturbation of the equilibrium of a particular community, meaning, and then the question is what's normal and what's normality. I don't think we know that either, but we do know that high diversity, meaning you have a lot of a substantial amount of microbes, that's a good sign. When that is absent or diminished, we're seeing inflammation, and that's across the board. There's no inflammatory process that does not provide as a correlate. I'm not saying this is a causative phenomenon, but as a correlate, inflammation equals dysbiosis in the gut. Chicken or the egg, animal models wise, and I'm looking again at Jim, this is known. In the absence of microbes, you do not have the phenotype of HLA-B27 transgenic rat, SKG mice, CIA, you name it, you don't have it. I don't know that you can translate that into humans. It's so challenging. How do you make a person live in a bubble without germs? It doesn't exist. And so, the questions of how do you modify or modulate the microbiome to improve both A, disease activity, inflammation, and B, a lot of what we're doing now is trying to understand how do you modulate DMARDs or other medications that we prescribe, which is published ANR on methotrexate, in this case in rheumatoid arthritis, on how you can, to a certain degree, predict response to therapy. We know now that human gut microbes metabolize methotrexate. We didn't know this. And it's fascinating. It's also true that if you take diltiazem, an antihypertensive, that medication gets metabolized by the gut microbiome. So there's a lot of unknowns and a lot of new fields that we really want to understand. It's true for immunotherapies or checkpoint inhibitors in cancer patients. So it's fascinating. We don't understand the mechanism yet, I don't think, but there's a lot there. Long answer for a very succinct question.
Most interesting. Thank you very much. It's been a kind of an ordeal, but we are just 2 minutes past our closing time. I'd like to thank the speakers for the discussions and the presentations, also our patient research partners, and of course the audience for putting their questions. I'd also like to thank the technical support and of course Spartan and Grappa, and then Elisa and Janine for putting this whole thing together. I want to encourage you to join Spartan or Grappa, and please look into the websites. And there will be a survey coming along. Please complete it in order to give us a bit of feedback as how we've done today and how to improve in the future. And I'd like to thank Pfizer again for providing their support. I'd like to remind you that we've got some upcoming seminars, which you can see on the screen right now. In particular, the Hot Topics seminar on race, age, and sex considerations, and the Global Perspectives and New Therapies in Development seminar that will more or less close in June, in May, and then in June, these sessions. Again, thank you very much. It's been a great seminar, and I'm looking forward to meet you next month or the day after tomorrow, perhaps the day to tomorrow in Europe time, and also Asian. Thank you.
Thank you.